Thank you, Ellie, for the kind introduction, and welcome everybody to this session. So today I'll be talking to you about what we've developed with regards to deep learned classification algorithms for pediatric CNS and solid tumors. I have no disclosures. So first off, we work in a diagnostic setting, and one of the challenges we're facing is that over the years we see an exponential increase in the number of different tumor entities that we recognize. So these are the three books that we used or use in the past. So ICD-02, ICD-03, and now the whole-exome classification. And this means that as a diagnostic lab, you need to be able to distinguish more and more of these tumor entities. Now this is possible, but for this you need more and more complex tests. And what you see, if the test gets more complex, the turnaround time increases. And this is a clinical problem because ideally you want to have a quick diagnosis for your patient. Now one of the things that we see used a lot, especially in the brain tumor field, is methylation classification. And this is a landmark paper from 2018 where they show that based on methylation profiles you can very accurately distinguish a lot of different CNS tumor types. Now this is great and this works very well, but it comes with a few important downsides. One is time. So it takes about a week to 2 weeks to run these arrays. And another big problem, especially if you want to do this in a clinical setting, is that you need 8 samples to fill the machine. So that means that sometimes if you don't have the number of patients, turnaround times might be much longer. And this is especially problematic if you're in a brain tumor surgery. And the thing with brain tumors is, usually you don't get a biopsy upfront to determine your diagnosis. So as a surgeon, you go in only with the radiology that you have seen before. So you have an idea of the tumor type, but you don't know the exact tumor type that you're actually doing the surgery on. And this is a problem, because CNS surgery really is a balance between trying to remove the full extent of the tumor and not doing too much damage to the surrounding tissue. And the problem is that the rate of resection you want to achieve depends on the tumor type. So for instance, for an ependymoma, we know that survival is very good if you manage to achieve a full resection. So then it's okay to do a little bit more damage with regards to the patient. On the other hand, if you have certain forms of medulloblastoma, we know that survival is independent of the extent of resection. So there you maybe not want to do too much damage to preserve function for the patient as much as possible. So this is the balance that you need to find, but it's impossible to distinguish these tumor types based on radiology that you have up front. So that's what started this project. So how do we get a detailed classification during surgery so that the surgeon can adapt the surgical strategy based on the results from this test? And that's where nanopore came in. Nanopore, as you all know, is extremely fast and methylation sensitive. And these are the two things that we need in this scenario. Now, although nanopore is extremely fast, it also comes at a cost, right? Because if you start sequencing, you start getting random bits across the genome. So it's like looking at an image, but only seeing 1% of the pixels. So this is an AI generated image, and this is showing 1% of the pixels, which is about the amount of data you get after 10 minutes of sequencing. Now, after about an hour, you have 5% of the genome, and this increases, but it will take up to 3 days to get the full image and to see that this is a dog on a mountain eating an ice cream. And this is a problem because you don't have that time during surgery. So we need to be able to develop something that can, within this first sort of hour of sequencing, deal with the data that is there and give you a classification for your tumor. And that's where we teamed up with some AI specialists from the University Medical Center. So this is Jeroen de Ridder and 2 members from his team, Mark and Carlo. And they have developed a neural network that is able to deal with this data sparsity. So the neural network doesn't really care that it only sees 5% of the methylation across the genome. This is enough for the neural network to give you a classification. Now this was done somewhere early 2023, and then when we had the algorithm and we've done the cross-validations, we were ready to do the first real-life sample. And one thing I should say, so this has all been trained on the methylation array data. So we use the array data that's publicly available to train the neural network, and then we use the model to classify the samples. And one of the things that is very nice about the methylation array data is you can sort of subsample all these methylation arrays to create many thousands of training examples from a single array sample. So by giving the algorithm all of the time only a couple % of the data, you sort of teach the algorithm how to deal with only having 5% of your data. Now, and this is where I wanted to go 2 slides back. So this is the example of the first run that we did intraoperatively. And in the bottom, in the yellow line, you see the timeline in minutes. So we got a call from the surgery room, And our technician walked to the surgery room and walked back with the tissue. That took about 16 minutes. Then we registered the sample, did library preparation, quality control. That took about 30 minutes in total, and then we could start sequencing. And after 30 minutes of sequencing, the algorithm gave a classification for schwannoma. And you can see in the plot on the right, sort of the curve of the confidence over time. So you can see that after 5-10 minutes of sequencing, it wasn't very sure about the diagnosis. But then after 30 minutes of sequencing, the line goes up above the 95% confidence, and it was very confident that this is a schwannoma. Now, this turned out to be correct. This was a little over 2 years ago. And where we are now is that we've sequenced about 80 of these cases intraoperatively. We do about 1 to 2 brain surgeries a week. And this has become our standard of care diagnostics for these patients. So this assay is now brought under our ISO 15189 accreditation. So it's really part of our quality control system. And we do this in a clinical setting. And what's important to notice is that for almost all of the samples, you only require about 0.05x genome coverage. So it's extremely shallow nanopore sequencing data. All right, so that's about the brain tumors. Now there is an obvious need for doing this extremely fast because you want to know the result during surgery. But in solid tumors, although it's not required to do it that fast, there is still quite a reasonable fraction of patients that presents and that requires immediate treatment. So you need to start chemotherapy immediately because of the clinical situation of the patient. And there it can also be very helpful to get a very accurate diagnosis in a quick time frame. So that's what we did next. So we've assembled a reference set from a lot of publicly available data sets, but also from our own biobank. And that now encompasses over 90 different solid tumor entities. And this is focused on pediatrics. And when we say solid, we try to include everything that is not in the CNS or in the bone marrow. So this also includes some of the carcinomas that you see in pediatric tumors. It includes brain germ cell tumors. It includes lymphomas. So really a large extent of samples are there. 92 entities in total. And this is what we got when we did a cross-validation on this cohort. So this is showing the F1 scores for all of the different tumor entities. And you can see that across the board for all of the different entities, the F1 scores are very high. So there is a very good performance of the algorithm in the cross-validation setting. But this is still cross-validation on the methylation array sample. So that is not the real deal nanopore data. So that's what we did next. So we dove into the biobank of our hospital and we collected samples there. And this is showing a summary of 465 samples that we sequenced on nanopore from all these different solid tumor entities. And what we see is that if you look at all samples combined, what we get is 89.3% of the samples are accurately classified. So that's already pretty good performance. But then if we only look at the samples for which the algorithm was very confident about the prediction, so where they got a 0.8 or higher score for that sample, we see that 97.7% of the samples get an accurate classification. So this is a very good performance on this set. And this is all done on actual nanopore data with again about 0.05 to 0.1x coverage. And this is if you look at that per tumor type. So what you see here on the bottom are the different tumor entities that are included in these 460 samples. And you can see on top are the numbers per tumor type. So here that you see, this is variable because this comes from our biobank. So more frequent occurrent diagnoses we have more examples of. But you see again that across the board there's very high performance on all these different tumor entities. So that's where we are now. Together with Sturgeon for the CNS and Toucan for the solid tumors, we can classify over 180 different pediatric tumor entities. And with this method, you can really get from sample to classification in under 90 minutes. So when there is a need for getting an accurate diagnosis fast, this is really a tool to turn to. And one more thing that I want to say, this is also very cost effective. So when you do this in an intraoperative setting, costs are about 200 euros per sample because you only require so low coverage, you can actually reuse your flow cells for a couple of surgeries. So you can just wash, store, use again a couple days later, wash, store, use again a couple days later. So then costs are about 200 euros per sample. And if you do this retrospectively on a Promethean, you can batch up to 24 samples on one flow cell and get enough data to do the classifications. So also there it becomes even cheaper if you want to do this retrospectively. So these are all the people who are involved in this work. Special thanks to everybody here on the slide. And thank you for your attention, and I'd be happy to take 1 or 2 questions.